Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Hirotaka Hasegawa. Dr. Hasegawa is an assistant professor in the Department of Neurosurgery at the University of Tokyo Hospital, Japan. He is the chief endoscopic skull-base surgeon at the University of Tokyo Hospital who has abundant clinical and research experience in the endoscopic surgery for skull-based lesions, including pit nets, meningiomas, chordomas, chondrosarcomas, as well as stereotactic radiosurgery for brain neoplasm and vascular malformation. He has gained rich international experience as a part of Mayo Clinic Neurosurgical International Fellow at Minnesota, USA, and he was honored with several awards and honors during his career in neurosurgery. We are extremely honored to have him today at our webinars, and today he'll be talking about endoscope as anywhere corridor to the skull base. The speaker for the second session of today is our honorable faculty from China, Professor Xinyu Yang. Professor Yang is a consultant in the Department of Neurosurgery at the Tianjin Medical University General Hospital, China. He is an expert cerebrovascular surgeon with a rich experience in clipping surgery of aneurysms. He was the previous host of the ACNS interim meeting held in Tianjin in June 2023, and he will be also hosting the WFNS complication meeting in 2024 in Tianjin. We are extremely honored and grateful to him for accepting our invitation to be a speaker at our webinars, and today we'll be talking about surgery of irregular paraclinoid aneurysms in the endovascular era. The chair for the first session of today's webinar is our honorable faculty from Singapore, Professor Vincent Eng. Professor Vincent is the head of Department of Neurosurgery at the National Neuroscience Institute, Singapore. He is also the co-director of the Endovascular Center and director of the Joint Neurovascular Service at the National Neuroscience Institute. He is the current Vice President for Clinical Neuroscience Society and immediate past chairman for the Chapter of Neurosurgeons, Academy of Medicine, Singapore. He is also a member of the Congress of American Neurological Surgeons and the American Association of Neurological Surgeons. He is an expert in endoscopic skull-base surgery and was also the host of the recently concluded meeting of the IFNA. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Naoki Otani. Professor Otani is the chairman in the Department of Neurosurgery at the Nihon University Hospital, Tokyo, Japan. He is an integral member of the ACNS delegation, which conducts workshops and conferences around the world. He is an expert cerebrovascular surgeon who has published several articles in various period journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kote, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Vincent Eng.
Hello, good day, everybody. Welcome to another round of the ACNS webinar. First of all, I'd like to thank Professor Yoko Kato for the kind invitation to chair this session, and also Professor Shibin, and much facilitated by Dr. Raja and Dr. Liu for this seminar. Today, we're in for a treat. Our speaker for this session is Professor Hirotaka Hasegawa. He is the chief endoscopic skull-base surgeon at the University of Tokyo and has abundant clinical and research experiences in endoscopic surgery for skull-base lesions. And he has also reached international experience as a past Mayo Clinic Neurosurgical International Fellow. His topic today with us is the endoscope as an anywhere door to the skull base, how to access a variety of skull base regions. We welcome Professor Hirotaka Hasegawa to give his talk. Welcome.
Okay, thank you very much for your great introduction. Again, my name is Hirotaka Hasegawa from the University of Tokyo. I've been working as a chief endoscopic surgeon here at the University of Tokyo for about 2.5 years after, finishing my fellowship at Mayo Clinic. Today, I'm going to share a little bit of my experience mainly on endoscopic skull-base surgeries. And hopefully this will be helpful for many, young neurosurgeons. As you can see from, the title of my slide, I believe endoscope is, great tool. I think with only endoscope, we can access most of the part of the skull base, believe it or not. So let me share my slide. And then before moving to my presentation, I would like to extend my gratitude to, Raja and Vincent and many other folks that have been supporting, this great ACNS webinar, and also Professor Yoko Kato, who has been organizing this great society. Okay. So let me briefly introduce myself, background. As Raja went over, I was a resident. When I was a resident, I'm mainly doing vascular microsurgery under Professor Tomohiro Inoue, who is one of the most famous vascular surgeons in Japan. This is very quick video, which is a very interesting case. As you can see here, this guy has, middle cerebral artery occlusion because of, the cardiac embolism. And this is, what we call, surgical embolectomy, which is a kind of abandoned surgery. Believe it or not, this is not a first forwarded video, but, because we needed to, recanalize the artery as fast as possible, I do everything real quick, just real quick to expose the middle cerebral artery. And this is when I was a resident. So when at that time, my main job was the vascular microsurgery. I had never thought about, I was gonna do endoscopic skull-base surgery at this time. But now, after that, I worked with Professor Masahiro Shin, who is a great skull-base surgeon here. And then after that, I went to Mayo Clinic and also learned a lot from, a variety of great mentors at Mayo Clinic. And now I'm here. So because of this background, my main concept of surgery is endoscopic microsurgery. Okay, so do microscopic fine procedures under endoscopic visualization. This is my main concept, and then I'm gonna go over this. So what do you think about the role of endoscope in skull-base surgery? I believe endoscope is not just a tool for Sellar lesion, but endoscope is the endoscope is a tool to access anywhere in skull base with minimal invasiveness, just like a Anywehere door that has been used by this blue time traveling robot in Japanese animation. And there are several important tips from my side for successful surgery, and then I'm gonna go over these tips from now. So the first thing is understand skull base and nasal anatomy. This is very important. This is very basic. Okay, so there are a variety of materials with which you can learn the skull base anatomies, including textbook, journal, webinar, just like this ACNS webinars, and cadaver calls and scientific meeting. And also, personally, we have 3D simulation system to help understand anatomy. We create this 3D simulation using CTs, MRIs, and angio, all integrated, just like this. With this 3D simulation, you can mobilize, like pull or push the soft tissues like this, or even you can drill the bone just like this to create, kind of virtual reality, just like the same surgical field, just like you can see in the real surgery. And also we can download this 3D simulation that just created to iPad, so we can check it later on during the real surgery. So this is a very nice system to check the anatomical relationships. The second thing is wide skull base exposure. I believe this is quite important. now you understand the anatomy, then you can safely and widely expose the skull base. Okay. So, and I believe this is quite important because it is necessary for fine, like I said, microscopic procedures later on. Perhaps my exposure is a little bit wider than the other neurosurgeons do, but this is just because I would like to do fine microscopic procedures freely. And also, this is very important. Normal anatomical preservation, which means, mostly, do not resect middle turbinate. This is very important in terms of postoperative postoperative nasal function. So this is my steps. Okay. First one is ethmoidectomy and releasing sphenopalatine foramen, and lateralize middle turbinate and superior turbinate, and inferior turbinate if needed. And then I would do interceptor dissection to reach the anterior wall of the sphenoid sinus, then do wide sphenoidectomy, real wide, and then do a skull base exposure. So this is the case of tubercular cell meningioma, slightly larger on the left side. So the exposure should be larger on the left side. I'm going to start the video. This is the ethmoid buller in the middle meatus. Using the drill, I completely removed the ethmoid buller like this, all the way to see the lateral recess of the sphenoid sinus. And this is a sphenopalatine foramen, which I drilled to open up to allow for the lateral retraction later on. And then middle turbinate and the superior turbinate are retracted laterally like this. And then sphenoid ostium is up and up. This is a wide access to the sphenoid sinus, but then I would do interceptor dissection. So I would, do most of the things from between the nasal septum. The same procedures on the other side. This is a sphenoid sinus, and interceptor dissection is completed to expose the olfactory filaments up here and the palato-vaginal canal here. And then the Bowman bone is removed to enter the sphenoid sinus. I would usually preserve the sphenoid mucosa with its pedicle on to be used for skull base reconstruction later on. Again, wide skull base exposure is very important. And then this is my exposure bilateral ICA and optic canals. And I would start the drilling of the skull base from the Sellar and then move up just for the safety purpose, just to confirm where I am. And then I would remove the bone covering the medial edge of the carotid artery, just like eggshell drilling, and flip it up, just same as the other, skull base techniques. And also the same procedures on the optic canal here. And I think this is very important to remove the medial edge of the sphenoid wing to allow for lateral access to the suprasellar lesion. And I'm removing a little bit of suprasellar bone here to get a wide access. The similar procedures on the right side, according to the tumor extension. And this is a completion of my skull base exposure of this guy. With this exposure, I was able to reach a vast area of the skull base like this. So I was able to remove the tumor. This is actually a very interesting case because you can see the SHA on the left side. This is the left side, even though I'm walking on the right side of the tumor. So this is a very dangerous case. As you know, SHA, if you injure the SHA, it may cause visual function loss. So we have to be very careful for these cases. So dividing the adhesion sharply and opening up the left optic canal to allow for the lateral access the superior lateral part of the tumor is now being progressively removed. This is the adhesion between the frontal lobe and the tumor. This should be sharply dissected because of the strong adhesion like this. After removing significant chunk of tumor, now you can see the entire course of the SHA, like creating a loop. So in this case, let's imagine we shouldn't cut the SHA because it could injure, it could damage the visual function. So I would do internal decompression step by step through the arcade of this SHA and sharply resect the adhesion between the tumor and the SHA, and then the tumor part should be coming through this arcade of the SHA. Now the entire part of the tumor is being removed. You can see nice view of the carotid artery there. Meticulous coagulation of the tumor origin, and yeah, I think this is a good resection. As you can see in the video, as you can see in the image, this tumor actually extends lateral to the carotid artery, but with this exposure, I was able to reach the lateral part of the tumor and safely remove it. The next important thing is hemostasis. Hemostasis is very important, and we have a variety of tools. So we have to, appropriately use these hemostatic tools. So we have to understand the pros and the cons of these hemostatic tools. This is very important. Again, my main concept is microscopic surgery, which means, let's think about microsurgery. We usually do counter traction to visualize where we should cut, right? So the same concept should be applied to endoscopic skull-base surgery. So this case is a tuberculous cellular meningioma. Again, SHA preservation is very important. You see lots of tough adhesion between the tumor and the SHA. And this is the adhesion between the optic nerve and the tumor. I put a meticulous and kind of careful counter traction using my left hand suction to visualize where it's adherent. And then to allow for bimanual surgery and good counter traction, I would use endoscopic holder to stabilize the endoscope and allow for two-hand surgery. And I would usually do lens cleaning using irrigation suction. And I believe this is not available in many countries, to be quite honest. This is widely available in Japan, but yeah. And this is another important concept of my surgery: double door dissection. I know, some of you guys don't understand what this means, but this is a very important concept to me. I would do strategic resection rather than just random internal decompression or step-by-step tumor resection. So let's say this is a tumor, covering the, posterior fossa arteries, particular basilar arteries. So when you see this is a Q, which means there is a, the Q for the dissection, then you can dissect between the tumor and the basilar artery, just above it. Then you can find the next Q here. This is AICA and this is the SCA. And then you can remove the tumor above such arteries. Then you can find the next Q here. So you can remove these tumors. Then you can find the next Q here. So you can find the vertebral artery and remove the tumor like this. Then you can find the, anterior spinal artery. This can be served, or this can also be served as a good cue, and then remove the tumor like this. With this, I believe we can minimize the risk of vascular injury by unintended encounter, which means, I would like to take full control of these vessels. And also, we can easily remove tumor by dividing it into smaller pieces. Also, skull-based reconstruction is very important, and I would use two types of sutures, which enables really easy running stitches. So this is what we call Kashime suture. This is, the previous case that I've showed. I would use collagen sheet like this, and then I would put PDS suture, just a few sutures to stabilize inlay fascia like this. I would usually do in situ suture. This is easier for me rather than rather than using knot pusher. Just this is my personal thing. Probably I will do another stitch here. This is the last stitch. And then I take a Kashime suture. This is a specially made suture which has a tiny metal device here. With this, you don't have to make any knot at all. Just do running suture, continuously do running suture, like just a baseball suture should be fine. And then after circumferentially do the suture, you can put your thread through this tiny metal device and squeeze it so you can stabilize the knot. And that's it. This is very convenient. The next one is verbal suture. This is a case with olfactory neuroblastoma. Again, I would stabilize the inlay fascia using the PDS plus like this. And then I would take bubble suture. This time I use Stratafix Spiral 4.0. And this has, so you don't have to make any knot using, this bubble suture. And because this bubble suture has multiple barb, which is, kind of spines, so it can stick into the dura mater. So it's not going to be loosened at all once it passes the dura. So just the same as the, what I did before, do the circumferential work and then just cut, that's fine. So these works very well. So let's move on to each case. The first one is Sellar thoracic lesion. Of course, we would do Transcellar approach for this lesion. This is a pit net, very basic one, not a large one. But the patient has slightly blurred vision on this side. So this is approach. I would say this is a binocular interceptor approach. And for the Sellar lesion, I don't usually remove the ethmoid sinus, but I would just lateralize the middle turbinate and the superior turbinate and open that the sphenoid ostium and remove the surrounding bone a little bit. And then the same procedure on the other side. And coming back to the nasal septum, I would enter in the, submucosal space up to, this is the, palatovaginal canal and vomerovaginal canal, a very famous landmarks for the skull-based exposure. The same procedure on the other side. remove the bomber bone, take it out, so we can use it when we reconstruct the nasal septum, wide skull-based exposure. Again, harvest the sphenoid mucosal flap and take down the intrasphenoid septa and to expose to widely expose the Sellar lesion like this. And then once you open the door, you'll see, I mean, in most of the case, you can find the dissection plane between the tumor and the pituitary gland if the surgical field is not contaminated with blood like this. So you can just follow this plane after a bit of internal decompression, just meticulously follow this plane. This is a very nice plane. Sometimes I would pull the tumor and do counter retraction to the normal gland to allow for the upper dissection and take out the tumor like this. So this is extracapsular dissection concept, which is very important. Complete resection is achieved. And so you may be thinking that, hey, it's possible only when the tumor is small. Yeah, but I would say, I don't think so. I don't think so. It's actually maybe possible, not all the case, but it's can be possible even when the tumor is very large, like this. So after removing the sphenoid, intrasphenoid tumor, adding some drilling to completely remove the bony invasion, then let's open up the Sellar space so we can find the the layer between the tumor and the normal gland like this. Just like the previous case, I would use this plane meticulously to accomplish extracapsular dissection. So this can be possible even when the tumor is large. Not all the case again, but I would say more than 80 or 90% of the cases, this is possible. The next one is suprasellar region. I will do transplant and transtuberculum approach. So this is a fairly large tumor, planum sphenoidal meningioma, involving the ACAs here and pushing down the chiasm here. The important thing is that imagine, this is the ACOM complex. So where is the artery of Huebner, which is very important perforators of the ACOM? Actually, the Huebner is also involved in the tumor. So let's see what we can do for this tough tumor. Again, wide skull-based exposure is very important, and the internal decompression is progressively performed to allow for good tumor mobilization. This is the optic tract, and this is ACOM complex, which is strongly adherent to the tumor. You can see here, this is the ACOM, very, very adherent to the tumor. Again, double door dissection is very important, just above the A1 to divide the tumor chunk into two smaller pieces. But be careful, for these type of tumor usually have pile feeding from the left A1 and many other involved arteries. In such case, point coagulation and the cut is very important. Again, this guy has a humor inside the tumor, and then there is a pile feeding from the left humor. Again, point coagulation and cut is very important to preserve the artery. Meticulously dissect the tumor from the surrounding tissues for the tumor. And this is a completion of surgery. I had to leave a little bit of tumor that was strongly attaching to the tumor, but I've been closely observing these tumors, and for now, there is no recurrence. The next case is more anteriorly located tumor, which should be treated with transcribiform approach. So this is olfactory neuroblastoma Cadish B, which means a good candidate for endoscopic surgery. Let me briefly explain the important procedure here. This is a draft 3 drilling. So this is mainly ENT procedure, but definitely must buy for neurosurgeons as well. With this procedure, you'll find the nasofrontal beak, which is located between the nasal space and the frontal sinus. And basically, draft 3 drilling means to drill out this nasal frontal beak from inside to allow for good access to the frontal sinus in bilateral maneuvers, with also doing septostomy here. So in this case, I collaborated with our ENT surgeons, and the first part was done by our our ENT surgeon. So this is draft 3 drilling, removing the nasofrontal beak to find the frontal sinus, adding the septostomy, so you find the tumor. And this is the anterior ethmoid artery, which should be cut. The same thing on the other side, anterior ethmoid artery should be cut. And then next part is me, neurosurgeon. So this is a very nice view, panoramic view of the tumor and the frontal sinus. So I first drill out the perpendicular plate so I can find the crista galli here, which should be removed to allow for anterior access to the tumor. And then circumferentially drill out the covering bone to find the posterior ethmoid artery, which should be cut. And then after removing the bone surrounding the tumor, I opened up the dura to find the olfactory nerves. The veins and the arachnoid adhesions are meticulously cut like this. And then finally, the olfactory nerve should be cut, because these tumors are basically coming from the olfactory nerves. And this is an unblock resection of olfactory neuroblastoma. And now the part of reconstruction. Again, I would use collagen sheet like this. And this time I use barbed suture for inlay fascia. Again, this is very simple. You don't have to make any knot. Just run the suture and cut the end, and that's it. And I would I place only fascia and nasal cartilage and nasal septal flap because of the postoperative radiation. Good amount of gross total resection was achieved. The next one is lower clivus, with which we should use transclival approach. So this is a clival meningioma involving vertebral vaginal artery. This is a 3D simulation. Again, wide exposure and clean surgical field is very important, and internal decompression to find the upper part of the vaginal artery, and then follow the course of vaginal artery, just like opening the double door. And this is a kind of tight adhesion, which should be cut sharply using scissors and some other sharp devices, and find the vertebral artery. Again, the same thing, just like opening the double door. You find the anterior spinal artery here. And finally, the tumor behind the vertebral union is pulled out and removed. And this is the final view, completion of the tumor removal. Thankfully, I was able to achieve gross total resection, and her symptoms recovered very well. So the next one is actually very tough case, upper clivus lesion. This should be, in most cases, I would use combined transplanum, transtuberculum, and transclival approach with pituitary transposition. So this is a posterior cranial meningioma involving the PCOM. As you can see here, the PCOM is completely involved with its bunch of perforators. Again, wide exposure is quite important, all the way from the planum sphenoidale down to the clivus, and also pituitary transposition to connect these regions. Internal decompression first to mobilize the tumor and find the left SHA, which is sharply cut like this. And then internal decompression to find the left PCOM, which is totally encased. At this time, I felt like that, it's not a good time to remove tumor around the PCOM. So I first did the double door dissection along with the basilar artery. So I divided the tumor into two smaller pieces. And after resection of the right part of the smaller tumor, I turned my attention to the PCOM and do internal decompression again to find the P2. And then this is the oculomotor nerve. Meticulously remove the tumor progressively, the trigeminal nerve and abducent nerve, and this is a completion of the tumor removal. So this is a final view. So you can nicely see the resection cavity here. I would say this is near total resection because I know very small, but there is a tumor remnant behind the left cavernous sinus. So I actually performed radiosurgery for this lady. So this is another case with upper clivus lesion, recurrent Cordoba, Sellar path, heavy particle radiotherapy. So I would say this is very fibrous tumor, very dangerous tumor. In this case, I use ICZ video angiography to find to detect the carotid arteries, progressively removed the Sellar part and the cavernous sinus part. And this is a suprasellar lesion. Because the tumor was really hard, I used maximal power of sonopet. This is a PCOM, which is also tightly adherent to the tumor. So needed sharp dissection, basilar artery and 6th nerve here. And then the tumor is progressively dissected from the right optic tract and remove it. So this is the completion of tumor removal. So you can nicely see the upper part of the upper entire part of the basilar artery here. For this case, I put inlay fascia, which is sutured here, and then put onlay fascia, and then nasopharyngeal flap to completely secure these materials. And this case also went well. Let's move on to the lateral skull base. With these lateral skull base regions, there are plenty of, a variety of approaches to reach these multiple lesions, and we have to appropriately use these ones. So first one is to access cavernous sinus. I would use direct transsellar and transcavernous approach using oblique endoscope. So this is a recurrent non-functioning pit net. So you can see tumors. It's actually a little bit tough to detect where the tumor is. But let's see this 3D simulation. So you can find the tumors like this. Actually, the main part of the tumor is wrapped around by this carotid artery, and in the posterior cavernous sinus, there is also a remnant tumor. So I'm going to go over the space and the ligaments of inside the cavernous sinus. This is very important. This is actually very important. So you'll see the carotid artery here. And then there are lots of, carotid cavernous sinus components, superior, posterior, and inferior, and also lateral here. And also there is dorsal clinoidal space, which is separated by the caroticoclinoidal ligament here. And also we have parasellar ligaments here. This is superior parasellar ligaments, inferior and posterior parasellar ligaments. So we have to understand these ligaments and the spaces so we can accurately detect the tumor location. Back into the patient image, you can see this is a tumor invading inferior part of the cavernous sinus, and this is a posterior compartment, and this is a superior compartment. So it's very important to understand that compartments are different. So this is a case. Again, this is a recurrent case, but I usually add some of the skull-based exposure to allow for wide exposure. So this is the cavernous sinus, and this is the Sellar part. So we can mobilize the pituitary gland like this, and then remove the Sellar, the bone of the Sellar floor, and a little bit of the clivus. So completely access to the petrous apex and the basilar plexus, cutting the cavernous sinus medial wall all the way up to the back end. And also, let's see, this is the parasellar ligament and the caroticocranial ligament. So using oblique endoscope to allow for good visualization of these ligaments, removing the tumor inside the cavernous sinus, and then connect cavernous sinus and the dorsal clinoidal space by cutting these ligaments. So this is a tumor inside the dorsal clinoidal space. Now you can see oculomotor nerve and the interclinoidal ligament like this. And then also cut the parasellar ligament. So you can mobilize the carotid artery inferiorly. And using the 70-degree endoscope, you can visualize the anterior part of the lateral cavernous sinus like this. So this is the inferior lateral trunk. You can even remove the tumor anteriorly to the inferior lateral trunk. And this is a tumor in the posterior cavernous sinus. I additionally cut the parasellar, the remnant of the parasellar ligament to completely mobilize the carotid artery anteriorly and to allow for tumor removal at the behind the carotid artery. And then I added tumor resection below the carotid artery to achieve complete removal of this tumor. So this is nice exposure of carotid artery and dorsal clinoidal space and the cavernous sinus. In this case, I would put collagen sheet, and then everything is covered up with nasal mucosa. Actually, this is a nasopharyngeal flap, not nasoseptal flap. And complete removal is achieved. So for the lateral access to parapharyngeal space and the infratemporal fossa, I would use EM3, which means endoscopic modified medial maxillectomy. This is a kind of ENT procedure, but must buy for many skull-based endoscopic surgeons. The indication is maxillary sinus lesion, parapharyngeal space, and the infratemporal fossa. And the benefit of this approach is to be able to preserve the inferior turbinate and nasolacrimal duct by lateralizing them. So this is a case of recurrent anaplastic meningioma after radiosurgery, so kind of tough tumor. This case, I cut the inferior part of the middle turbinate, and then this tumor actually slightly extended to the sphenoid sinus. So I remove the tumor inside the sphenoid sinus first. And then this is the lateral recess tumor. And then turning my attention to the lateral part. So this is the inferior turbinate. The middle side of the inferior turbinate is reflected to find the nasolacrimal duct. And this is a nasolacrimal duct you can see here. And then I dissect the nasal mucosa like this, remove the lateral nasal wall to find the greater parietal nerve and lateral pterygoid plate. And this is a medial pterygoid plate, which should be carefully removed. I actually add a little bit of exposure to the anterior surface of the maxillary sinus. This is what we call diarrhea approach, direct anterior lateral approach to the maxillary sinus. With this approach, you can get further lateral access, and you can also do multiportal surgery. So this is the internal maxillary artery, which has been coiled. And this is the medial pterygoid muscle, which should be divided to find the tumor here. And this is a trajectory via EM3, which is okay, but slightly too narrow. So I would use diarrhea exposure to allow for multiportal surgery and remove the tumor. You know, I'm inserting the endoscope from diarrhea trajectory and inserting the other instrument from the EM3 trajectory to allow for two-hands manipulations. Actually, this is really tough tumor, lots of adhesion to the surrounding tissues. So, actually, this is B3, and this is the carotid artery parapharyngeal segment, removing the tumor behind the V3 and near the parapharyngeal ICA, which should be located around here. This is the final view. You can see the parapharyngeal ICA, which was detected using the Doppler sonography. And this is a completion of surgery. I've said this is subtotal resection because of the bad adhesion. I wasn't able to take out all the tumor, but should be considered as a good resection. So now the time is getting short. So this is actually not an endoscopic transnasal case, but this is an endoscopic transcranial case. Let me briefly go over this case. When the tumor is located lateral to the carotid artery, it's kind of difficult for me to access to the tumor from inside, from the medial side of the carotid artery. In that case, I would use endoscopic anterior transpitalossal approach. I create 3 by 3 centimeter small craniotomy and expose the Kawase triangle under endoscopic magnification, just like this. And cut these MMA and interdural dissection to find the tumor around the V3 portion. And again, this is a Kawase triangle, and then the top part is very soft because of the tumor invasion. So I drilled the tumor meticulously to find the lateral portion of the carotid artery. With the oblique viewing endoscope, I was able to see real caudal part of the ICA. And then coming back to the superior side, I add the little bit of interdural dissection to allow for mobilization of the dura and meticulously remove the tumor until we see the carotid artery. And this is a dorsum Sellar. We find that. So this is a final view. We can nicely see the V2 and V3 and ICA here. All procedures are done under endoscopic magnification through this small craniotomy. So this is actually very nice surgery. and near total resection is achieved. What about the jugular foramen and the hypoglossal canal and some other inferior part of the cranial vertebral junction? So if the tumor is located medially, I would use endoscopic transnasal approach to allow for good visualization of the VA, and this is the lower cranial nerves. Unfortunately, the tumor is strongly adherent to the vertebral artery, so I had to leave a little bit of tumor attaching to the VA here. And additionally, remove the jugular tubercle to completely expose the hypoglossal canal, and also remove the tumor around the canal. And also, this is a jugular foramen Parasellar bother. I think this is the limit. This is the maximum limit of this exposure. The medial side of the jugular foramen. We are not going to be able to reach lateral to the jugular foramen of using this approach. But this is a very nice view, the panoramic view of bilateral hypoglossal canal. So what if we have a tumor lateral to the jugular foramen and the hypoglossal canal, which is this? This is actually jugular foramen schwannoma lateral to the hypoglossal canal and the jugular foramen. In that case, I would do endoscopic transmastoid approach. So again, very small incision, 2.5 centimeter mastoidectomy to find the sigmoid sinus. Everything is under endoscopic visualization. This is a tumor. And this is a lower cranial nerve. This is actually 11th nerve. And then dissect the tumor from the dura. The anteriorly, we can find the 7th nerve here. And then deep inside the surgical field, I was able to find the parapharyngeal portion of the carotid artery and remove the tumor. And turning attention to the caudal part, I was able to remove the tumor just below the lower cranial nerves. And finally, this is a medial superior part of the tumor, which is removed. This is a panoramic view of this great approach, lower cranial nerve and the parapharyngeal ICA. And compared to microscopic view, I think you can feel how we can entertain the panoramic view of endoscopic surgery with this very narrow corridor. And this has been accepted in general neurosurgery. So, okay, let me wrap up my presentation. Again, I believe this is very important point for endoscopic skull base surgery. First, understand the skull base anatomy. This is quite important basic skill, basic knowledge. And endoscopic microsurgery concept is very important, which means wide skull base exposure, two-hand surgery to increase maneuverability, hemostasis for clear visualization, and always do counter retraction to visualize where we should cut. And then strategic tumor removal, let's say internal decompression to mobilize the tumor, or if the tumor involves artery, I would do double door dissection just above the artery. And no CSF leakage is allowed, so I would do dural sutures in most cases. So this is my last slide. Let's master a variety of endoscopic skull base approach so you can reach anywhere in the skull base. And again, thank you very much for organizing this great meeting, Professor Yoko Kato and Roger and many other folks. And thank you very much for the for inviting me to this great webinar. Thank you for attention.
Thank you, Professor Hasegawa, for your professorial lecture. You indeed have convinced us that your endoscope can reach everywhere from the top to the bottom, to the left, and to the most extreme lateral aspects. We do have one question on board from the Q&A session. It's from Dr. Harsha Parekh, mentioning whether your endoscopic holder is robotic or who moves your scope for you during the surgery. and whether your scope holder is patented. Actually, similarly, the question is, in our unit, sometimes most of the time, the neurosurgeons and the ENT surgeons work together. You did show some cases when you were reaching frontally that you would work with the ENT, but it sounds like most of the cases you do on your own. So maybe you wanted to tell us about your endoscopic holder and how do you do your partnership? Thank you.
Okay, thank you very much for the question, Dr. Harshit Parekh. Actually, this is, actually, this is patented. This is Mitaka's Japanese medical company. The name is UniArm. So this is worked with gas. I think it's a nitrogen gas. I don't know for sure. But, this is a robotic endoscope holder. And then who manipulates this? I am doing it. Yeah. So like Vincent said, in most of the cases, let's say 98% of the cases, I do everything by myself because, our ENT surgeons are very busy. Actually, we have really good connection with each other. So they kindly check up, post-operative, the nasal condition, thankfully, periodically after surgery. But for the surgery part, they have their own practice, which are very busy. So I would do everything by myself.
Thank you and congratulations. I'll hand the session over back to Dr. Raja for the next session. Thank you very much for everybody.
Well, thank you
Thank you
very
very
much. It was indeed a 2-day course of the skull base with endoscope and very interesting. Congratulations on your good work, Professor Hasegawa. If there are any questions, we could take a few. Liu, would you like to ask anything?
Yeah, thanks, Raja. Thanks, Professor, for a very nice lecture. I have two questions for you, Professor. First is, I think it's a brilliant idea to put a knot, just like what the tailor always use when they're doing a clothes. But how big is the knot that you think that will not pass through the soft tissue? You won't get dislodged. In your experience, just a single knot at the end or 2 times or whatsoever, from your experience. My second question, Professor, and you use 70-degree scope for certain cases. And do you think that endoscopically is the instrument are developed enough to go for the angle? I mean, instrument to be used, you can visualize, but in terms of instrument access, do you have enough instrument to do that kind of access, or you think that more need to be developed? Probably last one more extra question. You show us that you open up the cavernous sinus for non-functioning tumor. All this while I was hearing a functional tumor where people go very aggressively. So in average neurosurgeon hand, do you think this should be attempted? Thank you.
Yeah, thank you for asking a great question. So for the last question, actually, yeah, I agree with you. So if this is, functioning tumor, definitely we should do that. But this is non-functioning tumor. So, sometimes we shouldn't do that. But for this particular case, the tumor progressed real quick, actually. So I was kind of afraid whether the tumor became malignant or not. So I decided to take out all of the tumor. And that's why. Yeah, and you are true. Don't be too aggressive inside the cavernous sinus. This is also true. But when the patient is very young, or when the tumor has a possibility of malignant change, then even with non-functioning tumor, I think sometimes we have to be very aggressive. And to prepare for that case, we have to be very accustomed to, manipulation inside the cavernous sinus, knowing anatomy, how to manipulate on the cavernous sinus, and then the structure, the detailed structures of the ligaments. These are very important points from my side. And as for the second question, 70-degree endoscope, actually in my hospital, I I have lots of, malleable instruments. So we can bend a little bit, just as you like. So with these instruments, for the time being, I feel it's okay. One thing I would like to add is scissors. I don't think there is actually. I know there's one scissors with which we can bend slightly a little bit, but the bend angle is not like this, but like this, right? So I would like to bend here, but these instruments can only be bent here, and with this bend, I don't think I can reach the deep part of the cavernous sinus, especially when using 70-degree endoscope, which is really weird angle like this. So that's my one little concern. And then hopefully in the near future, someone develop a very nice micro instruments. And sorry for the first question. You mean the size of the knot or size of the suture?
Yes.
Or
Yeah,
needle?
the knot, size of the knot that you think is safe, that you will not dislodge. Yeah.
I see. I think it's completely safe, to be quite honest. You mean that, I make knot using 5-0 PDS, right? And otherwise, I don't have to make any knot using the other sutures like Kashmir and Stratafix spiral, because they have their own, system to allow for knotless suture. So you mean the PDS knot?
Yes, yes. I saw you have the knot even before you suture
Yeah.
Yes. So is
Yeah,
a
because
single knot is enough?
I believe so. I believe so. Because now the suture is really very nice. It's getting really smaller and smaller. I mean, the gap between the needle and the thread is now real small. So I don't think it causes big hole, to be quite honest. It's just a pinhole, so we can tightly we can get watertight closure. And also for the regarding the reason of the the PDS suture, I actually found that it would be easier for me to stabilize the inlay fascia first, rather than just doing, running a suture. With this, I can kind of know where to, put my needle through, because it's already stabilized. That's my concept.
Thank you very much, Professor.
Thank you very much for asking that.
Professor Otani?
Yeah. Thank you. Thank you, Professor Hasegawa. So it's great technique and meticulous and so fine technique. So one question. So have you ever experienced uncontrollable bleeding from the cavernous sinus? Have you ever experienced?
Actually, no. I've never experienced that kind of, big bleeding from the cavernous sinus. I mean, actually, I believe bleeding from the, basilar plexus is more bigger than the bleeding from the cavernous sinus. But even with the basilar plexus bleeding, I think we can make a good hemostasis using, flowable or hemostatic materials. So, but it's also important to raise the bed and, to allow for decrease the intersinus pressure, which is very important.
Yeah, thank you.
Yeah.
Thank you.
Maybe I was just lucky
Okay.
guy.
So,
but, yeah.
sometimes direct injection of the fibrin glue to the cavernous sinus. It's easy to control the cavernous sinus from the craniotomy. So I think it's
sure.
Yeah. So, And in such cases for the venous plexus, for the vaginal plexus, so preoperatively, will you to go, would you, expected in such cases from the vaginal plexus venous bleeding? Preoperatively?
Yes.
Yeah.
Yes, exactly. Yeah. Especially for the case with, let's say skull base Cordova in the clivus lesion, and, skull base meningioma in the clivus, and also actually the upper clivus lesion is, they bleed a lot. Because we have to take them, because we have to go through the cavernous sinus and the vaginal plexus as well. So there are a lot of bleeding. I would say 200 milliliter just in one surgery, which is quite a lot for me.
Thank you.
Well, thank you very much. One thing I have noted with Japanese neurosurgeons is their obsession with the noting. If you are not able to put the note endoscopically, you are not a good surgeon, is what it seems. But I don't know why.
Yeah, I mean, well, just I would like to decrease the possibility of postoperative CSF leak. That's all. By stabilizing these postures.
Right. So we have seen Professor Tadashi Watanabe's note pusher and also the Osaka sliding note by Professor Takeo Goto, and very interesting. So once again, thank you very much, Professor Hasigawa and Professor Vincent, for this wonderful session. And we have update from Professor Shubin that currently we have around 1,370 people who are live on YouTube, WeChat, and Zoom. So thank you very much. It was a very interesting session. I'll hand over to our second chair, Professor Naoki Otani, who will say a short introduction and invite our Honorable Professor Shinyu Yang for his lecture. Professor Otani.
Thank you, Dr. Raja. And so second talk is from the Professor Niu Yang from the China. So entitled Surgery of Irregular Paraclinoid Aneurysm in the area of the flow diverters. So for the paraclinoid aneurysms, in Japan, many institutes has decided to select the endovascular treatment as the first choice. So because it's easy and short operation time and less invasively, but sometimes we will sometimes encounter the situation that needs a direct surgery for these paraclinoid aneurysms. So then we have to know the knowledge. So surgical tips for the safe clipping such aneurysms. So I have been looking for these lectures. So would you please, Professor Yang? So
hi, I'm
yes,
here.
welcome your lectures, please.
Okay, thank you, Professor Anthony. I'm a pleasure to be here to be presenting this evening. So I'm very glad, very pleasure to see many old friends, Professor Liu, and after half year we have now see, and thank you very much for visit to Tianjin in the June. Thank you for giving us the opportunity to hold the ACNS offline meeting. It's wonderful. Thank you. And so nice to meet you. And sorry for Vincent. And from the beginning, I say you, I'm wonderful, this guy. I have seen him, and I now cannot remember because we just say in Cape Town. Thank you, very nice kind of accommodation for me. Thank you very much. This is my great opportunity to share my ideas or share my recognize for the paraclinic aneurysms. So thank you to ACNS, Professor Kato and Professor Xubin, and Raja also the same. Thank you. So let me share my screen first. Okay, this is my talk today. I'm honored to be presenting here today to show my acknowledgement to the paraclinical aneurysm and its related treatment issue in the time of flow diverter time. As we all have know that aneurysm is not rare disease. It's a very common disease for the people. Is a kind of about 3% people who harbor aneurysm in their brain. But the annually rupture possibility is about 10,000 1 to 2 people per year. So, regarding the people population in our society, the aneurysm and its rupture is a big problem for us. So, because the aneurysm is not a malignant disease like tumor, like a glioma, we have the opportunity to treat the patients with some very good prognosis. So we need to improve our treatment and our methods for the aneurysms. Paraclinical intercranial artery carotid artery aneurysm is one of the most difficult positions we have to deal with. To my acknowledgement, the internal carotid arteries have many methods to divide it, and the traditional method to divide the internal carotid artery is first is divided into 4 segments according to the radiology method. But after the anatomy started improved, the internal carotid artery, and we separated into 7 segments. But for the clinical and the neurosurgical methods regarding to see where is the aneurysm in the intracranial artery, we found that the most important thing is that the internal carotid artery entering the dural matter. That means the dural matter covering the cavernous sinus is the most important memories that we should divide the internal carotid artery, which is in the brain or outside the brain. Because after the internal carotid artery penetrates the cavernous sinus and into the brain, if this segment of the internal carotid artery with aneurysm, it means that if the rupture of the aneurysm happened, that means the subarachnoid hemorrhage will happen. Or for more serious conditions, there will be the hematoma, and ICP will rise very quickly and take the patient to a very bad situation. But if the aneurysm below the memories, the dural memories of the cavernous sinus, even the aneurysm rupture, it will be a DAVF in most serious conditions. So for our surgery, from the point of open surgery for the paraclinoid internal carotid artery aneurysm, the anatomy is the first thing we should know about the related issues. So the ACP and the durals, 2 layers of durals we should know. when we need to remove the ACP and open the dural ring of the dural mirrors to open to see the internal carotid artery and its aneurysms. So many studies have shown that there are different aneurysms with different directions and different size and different methods. We can recognize the aneurysm. We can find this data on so many textbooks like UMass neurosurgical neurological surgery books and other tech and other books. So in the summary, we have in the old time, about 20 or 30 years before, when we treated the paraclinical internal carotid artery aneurysms, the first method is to remove the ACP and clipping the aneurysm. And the second method is that tripping and bypass. So when I was a young neurosurgeon, when I started in my residency, I see my teachers and the mentors, they treating the internal carotid artery and performing bypass surgery with some sufferance and suffering veins and radical arteries. They do great jobs for the unclippable paraclinical internal carotid artery aneurysms. But the recent 20 years with the in progress of the internal interventional technologies, stent and coiling and with stent assist or without stent assist methods developed very fast, and a lot of paraclinic internal carotid artery could be coiled with or without stent. And especially recent 10 years after the first flow diverter used in the US in 2008, and also in the recent 10 years in China, the big numbers of use of flow diverter give us a very good choice to treat the paraclinoid internal carotid arteries aneurysm. But even modern times, we have two methods of clipping and coiling or FT to treat the aneurysms of IC. But we should summarize the advance and the limitation of these two methods. The advances of clipping for the paraclinoid IC aneurysm is that this is the first is the tunica intima healing. That means after clipping, the inner matter of the vessel will be healing and by the clipping method. This is no other method could compare to. This is immediately healing of aneurysm. And without any problem, we worry about the thrombosis and the thrombose, we have to use some antiplatelet medicines to deal with this complication. So this is first, and this is the best method of the clipping for any aneurysm. And I think until now there's no other method would be better than this, than clipping. And another advantage is that there's lower recurrence of clipping than interventional methods. And for the third question is that if we have the same levels and we have same techniques all over the world, all over our vascular surgeons, I think the safety for ruptured aneurysm, for open surgery is safer, and because with the open surgery we can see the rupture points, we can control the bleeding, we can do anything we can do to deal with it. But if the intra-procedure rupture happened, the most serious complication is that the aneurysm rupture on theater. If this condition happened, even if we perform open surgery, we perform any other method to rescue the patient, is no better than open surgery. We can deal with the rupture on the theater. So this is the most advances of clipping, and I think we should keep the method of clipping aneurysm until now and even for the future. But the limitation of clipping is that open surgery cannot be accepted by every people, every doctor, even the patient. So for myself, regarding this issue, I always think that if I'm a patient of aneurysm, what's the method I would like to, what the method of the treatment I would like choice? Definitely the interventional method without open surgery, I'm a prefer. So we cannot regard the advances of interventional methods like coiling and FD. That's the best thing is that is one word without craniotomy. But the limitation of coiling, especially of standard-assist coiling and FD, is that the patient need antiplatelet medication and the recurring and off-label use. So regarding our history of treating of the paraclinoid aneurysm, we can see that use the traditional method of stent-assist coiling, we can achieve a very satisfied result. With the stent, we can definitely coil the aneurysm. So the patient can recover. The patient can, with a very low recurrence possibility after the treatment. So why not we like the methods? So even I have unruptured aneurysm like these people, I would like my tumor, my aneurysm to be treated by the interventional methods. But with the advance in recent 10 years, the flow diverter gave us more hopeful treatment choice for the patients. And we can see that with even very giant aneurysm, we can treat these patients with flow diverter combined with coiling to reduce the complication like rupture post-stenting. And this another advantage is that with this method, we can perform the operation without craniotomy. The most important thing that the people, patient, family, and anybody care about. Without the craniotomy, we can treat the intracranial lesions. That's the most important thing. So we can see that we can achieve very good result. But things not always dissatisfied with the paraclinoid intracranial arteries, because although the FDA of US approved the use of FD for the ICA, but they give a lot of limitations, not only what we can see in the best suitable cases, the lot of other conditions, they are not included in FDA indications, like this condition like bleach-like aneurysm, this circulation aneurysms, post-circulation aneurysm, previously treated aneurysms, acutely ruptured aneurysms, and dissecting aneurysm and pseudo aneurysms. This, if you use FD in these aneurysms, you are off label. If there's complications of bad prognosis, the doctors facing the risk. So in summary, to the FDA of US, of the indication of FDA, we facing so many questions. We still have rupture aneurysm, small aneurysm, BB aneurysm, atherosclerosis aneurysm, traumatic aneurysm, and so on. So what will we have to do with these aneurysms? So I'm the neurosurgeon training after open surgery and performing vascular surgery recently in most about 10 years. And in my mind, the open surgery is my first choice for all the diseases if the patient could accept the method, because if this method works, there's best prognosis. So with the aneurysm, when we encounter whether ruptured or unruptured, recently we have new technologies like neurovascular imaging technologies, and we can perform surgical planning for each individual patients, and we can perform proximal control, we can relax the brain, we can perform sharp dissections, we can remodeling the aneurysm by clipping, and we can have keyhole approach for open surgery. So this is the recent 20 years approach, at the same time interventional technology apply to aneurysm. So I think open surgery could preserve for so many conditions of aneurysms. So like this small aneurysm, this is a ophthalmic in IC aneurysm. With traditional method, we would like to clipping it, but in the old time, about the 20 or 30 years before, this aneurysm have some difficulty to clipping it. It's because it's covered by the optic nerve, and the approach was obscured by the ACP. And but if this small aneurysm, we want to perform interventional treatment, is very small, and if we perform FD, I don't know, this so small size aneurysm will have the best prognosis. So we perform keyhole approach. So this approach I was learned from Professor Juha from Finland, and I performed this kind of approach for most of the anterior circulation aneurysm, more than 90% in my hospital, and I think this is very quickly and time, not only time saving but very safe for particular patients. So I would like to introduce one video of aneurysm clipping of these patients. So after this is very small size of craniotomy, this such as the key, also we call the keyhole approach, like after Professor Bandensky, who event and introduced this keyhole approach to many other countries. We can perform this operation with modern neurological images and the neurological surgery techniques. I think the microscopy, high-speed drilling, and with improvement of the instrument of open surgery, we can perform the surgery safe and better. So for this small aneurysm, we need to remove the ACP first. So you can see with the high-speed drilling, we can drill off the bones of the optic nerve, the upper cover of the optic nerve, and ACP and the optic structures. These things we need to take care about it. It's that when we drill of the bones of the ACP, we need to cooling it with standardly the water injection, and with the excavator, we need to remove the water and the small particulars of the bone after the drilling. So we can do everything clearly. We can do it with even if with a very narrowed keyhole approach. But we can do it. We can successfully remove the ACP, and we can finally see the aneurysm. So we can see that the drilling needs patience, need very standard hands, but other people, after several cases of training, we can do it and do it very successfully. So I want to encourage the young neurosurgeons, don't forget, don't give up your knife, don't give up your drill. We can make it, we can do it very successfully. So after drill and remove the ACP, we can cut the dural covering the optic nerve and the dural ring of the IC, internal carotid artery. So we can see the aneurysm. So after seeing it, we think that one clipper is the best choice for this patient. It's not it's not only for the treatment of the patient with best prognosis and without recurrence, but also the patient can recover very quickly. I'm very thankful to Professor Yuha, who teaching me for this small, very small keyhole approach for these aneurysms. Another condition is that the blood ballistic like aneurysm. So with this kind of aneurysm, we need to deal with very hard work. We know that even if this aneurysm treated by the FD or this coiling is not on its label, but is off-label work, and we need to do it with very carefully, and we are not sure what's the prognosis of this kind of patient, and so we decided that this BBB aneurysm need our open surgery technologies. But for this kind of aneurysm, we should keep the open surgery and bypass and primary metro control and many other methods like the stitching, remodeling, clipping, and bypass to deal with if the aneurysm ruptured and cannot be only treated by clipping. So this aneurysm, we face the BB aneurysm, we have to open this aneurysm by transcranial approach. So after sharp dissecting, we go to the optic nerve and the internal carotid artery. But with the microscopy and sharpening dissecting technologies, we can go to the aneurysm very safe, very clear to see it. So after this kind of dissection and the control of the internal carotid artery in the neck, we have the confidence we can deal with this kind of aneurysm. So even after seeing the aneurysm and the optic nerve and the internal carotid artery, we need to dissect it and more to see the clearly where is the aneurysm and what is the real memory of the aneurysm. So we need dissecting with scissors, which means the sharpening, these dissecting technologies. We need to do it very, very deeply. So after dissecting the memories, ironic memories between internal carotid artery, aneurysms, and the optic nerve, so we can see it very clearly. So we think this small and BB aneurysm, after clipping, the patient is safe. For the future time, because this patient is very young, only in her age of 30, she have long time of surviving. So this kind of treatment will be the best choice. So this is the post surgery CT scan. We can see we have a very good result. Another case is that if we meet a very small aneurysm, in this aneurysm, we have found that on the DSA, the diameter of the aneurysm only 1.7 milliliters. In the older time, that means about 30 years before, we cannot diagnose it. Even if the patient with SAH go to the hospital. But with this small size aneurysm with modern radiology technologies, after DSA, we can find the aneurysm for the patient of SAH. So a very small clipper is the very good choice for this patient. I'm wondering if now at now time the interventional methods for this small size aneurysm is not suitable. So we can see for the keyhole approach again. So we can relax the brain and by release the CSF in the very early time after rupture. This is another point. The first 24 or 48 hours after rupture, there is very less subarachnoid hemorrhage, very less brain edema, and less time of higher intracranial ICP. So the brain could be relaxed very well. So with the endoscopy and with the microscopy and sharpening dissection technologies and the modern technology of clipping, we can treat this small aneurysm and keep the anterior coronal artery patent. So it's very important for the patient for her prognosis. So we can see after surgery, this is on CT scan. There's no questions. So the patient only 7 days after surgery for a HH 203 grading patients after surgery. The patient recovered very quickly. We think this is a good choice for this patient. Another example is that some aneurysm is associated with atherosclerosis. We can see this small aneurysm covered by the optic nerve, and in the proximal there is a calculation and stenosis of the internal carotid artery. If we perform FD or stent assist coiling for this patient, is not so good because this calculate and the stenosis, we cannot deploy the stents very good, but with the open surgery, we can see the aneurysm and we can see the atherosclerosis. So we can apply a clipper to the aneurysm. So with the modern neurosurgical technologies, so we can sharply dissecting for the aneurysm, for the clinoid, for the subarachnoid memories, and release the CSF. For this case, we don't need to remove the ACP totally, but we just need the space to put the optic nerves side a little bit to other side, so we can see the aneurysm. So for this case, we don't remove the ACP, but only open the cover of the optic nerve, 3 to 4 milliliters, so we can see the aneurysm like which is shown on the CTA. So a curved clipper is performed, so we solve the problem of the patient. So we think that the clipping of the aneurysm is a good choice. So finally, we have another case for this surgery examples beside the internal carotid artery, internal interventional technologies like this one. This aneurysm is, there's no neck. There's only aneurysm connect with the internal carotid and the ACA and MCA. If we coil it, there's no good method, and we don't think there is good result. So we performing remodeling clipping for this kind of aneurysm. So after the dissecting, after the open, we can see the aneurysm, and with the use of several clippers, and the sonic. We detect the internal carotid artery and MCA. We can gradually reduce the volume of the aneurysm. We found that with the gradually reduce the volume of the aneurysm, the tension on the wall of the aneurysm is reduced. We can perform more clippers and remodeling the aneurysm better. So after surgery, the patient recovered very well, and on the post procedure CT angiography, we can see the MCA and ACV keep very nice. And finally, we have another cases to for our discussion, and that is the patient with craniopharyngioma and the treatment. The treatment is open surgery and internal radiology with I-131. The radio surgery for the craniopharyngioma. But near 20 years post the treatment of the tumor, they found that there is signals of the life size of near internal carotid artery. They think that's the recurrence of the craniopharyngioma. But when they go to our department, on the CT angiography, we found that lesions are not a recurrence of the craniopharyngioma, but it is an aneurysm, irregular aneurysm. I think we cannot conclude that this aneurysm is not the the complication of treatment with internal radiology treatment of the craniopharyngioma. That means it's maybe tumor complication of the internal carotid artery. But with this aneurysm, we try to treat it is that if we perform the interventional methods, the coiling and stent assist coiling is difficult, but the FD is so less cases successfully reported. We don't have the confidence to perform FD for these patients. So even if we perform clipping for this patient, we don't have the we don't also have the ambitions to successfully clipping the aneurysm, because if it's pseudo aneurysm, the clipping will be disaster for this patient. So finally, the decision is that we perform high flow bypass. So we harvest the suffering vein from leg of the patient and perform high flow bypass. So this is the studying of the neck internal carotid artery, the C1 segment. So I think that compared to clipping the paraclinical aneurysm and this bypass is not so difficult. It's only need us to make these surgeries successfully. And this patient is after the open surgery for cranial pharyngioma and the internal radio surgery treatment. The bypass is some difficulty in the neck. but fortunately, the patient recovered very good. This is a very fortunate patient treated with the neurosurgeon in Tianjin with open surgery for cranial pharyngioma and high flow bypass in one patient. I'm very thankful to the patient and his family, who is very confident with the neurosurgeon surgeons. So in the summary for today's presentation, I would like to summarize my talk in several points. The first is that multiple that means plastic clipping method and basic techniques for paraclinoid aneurysm is very important. We should practice and observe the success cases and to keep the technologies for these patients. And high flow bypass is alternatively method for some patients. And the third point is that flow diverter is becoming the major method for in current strategy inject paraclinoids into IC aneurysm. But please remember that this method is only suitable for the aneurysm with good radiology images of the internal carotid artery. If there's stenosis, if there are some atherosclerosis indications for the internal carotid artery, the flow diverter isn't, and even if for the coiling or stent assist coiling, and is not very suitable. So, in summary, the choice depending on the physiological features of the internal carotid artery is mostly important things. The right choice is the first, and the second is we should have the both interventional technologies and open surgery technologies in our hands. That's my presentation today. Thank you very much. Okay.
Thank you. So, Professor Yang, so
Hi.
very educational presentation and so about the paraclinoid aneurysm from basic anatomy and decision making and so until surgical treatment in details. So based on you are so much experienced. So any question and comment from the
None from the
question.
audience.
No
But I
audience.
would like to ask one question to Professor Shinji.
Okay.
It's like when there is large or large to giant paraclinoid aneurysm, the suction decompression is a very good technique. We can do it through the superior thyroid artery or a direct puncture to the carotid artery. Well, this has been a large series of around 16 to 20 patients published by Professor Naoki Otani himself, and we have also tried it in our institution, and it has been a very useful technique, the retrograde suction decompression for paraclinoid aneurysms. Have you tried it in your center?
Okay. Thank you, and for the very nice question, and to my acknowledgement, and for the suction of the giant aneurysm and remodeling it and clipping it, is a great technologies with prominent control for the internal carotid artery and suction the aneurysm to reduce the volume of the aneurysm. So we have the opportunity to clip it and remodeling for the internal carotid artery. I think it's a very great technologies. For this kind of aneurysm, recently, especially recent 5 years in my department, all these aneurysms return to FD. We turn to the flow diverters because the first question is that the choice is depending on the patient. The patient would like to choose the internal interventional technologies without craniotomy, and people don't like open. And the second is that is from the technology consideration. If we suction to reduce the volume of the giant aneurysm, not only we have to occlude this segment of internal carotid artery, but also we need to, after reduce the volume, we need to carefully to take care of the aneurysm wall, and near small arteries like pica and anterior choroidal arteries to keep the patient safe without complication after surgery. I think it's for me it's a complicated technologies. We need to occlude the internal carotid artery, the distal cranial artery, and the PCAM, the ACA, MCA, and dissecting the aneurysm wall from the adjoint structures. It's time cost. I'm not dare to try it within 20 minutes. If we perform it after more than 20 minutes, maybe we need a bypass for surgery first. So from these two considerations, in recent 5 years in my center, we turn to the treatment method of unruptured giant internal carotid paraclinoid arteries aneurysms to flow diverter first, and the second, we try this open surgery.
I understood. Because obviously people will opt for a less invasive procedure as far as they're concerned. Well, we have Professor Jorge Salazar joining us from Ecuador. Yes, Jorge, you can ask a question.
Hello, good morning to everyone. Very interesting this meeting. I would like to ask Professor Yang, what is your conduct regarding small paraclinoid aneurysms? Do you always operate endovascular or follow up? What is your treatment of preference? Thank you.
Hi, thank you, Professor Jago. Thank you for your question. Regarding very small aneurysm in the paraclinoid segment, I always and my colleagues we always discussed before each cases in my department. In our department, we think that very small aneurysm, we facing the technology difficulty of interventional treatment, because the very small, regarding very small aneurysm, with the first choice of flow diverter, the flow diverter needs sometimes the flow diverter needs coiling as I said, but the coiling is not dense, very dense coiled. So with this method, we have to left much more spaces than ordinary standard assist coiling. So with the small aneurysm, the after FD we cannot if we use coiling, it's almost compared to giant and big aneurysm, is almost without coiling like the same condition. So with a very small aneurysm and only FD, we think that with our open surgery technologies, the better choice is the clipping. And another choice is that small aneurysm, sometimes we perform operation, it's a ruptured one. And for more than half of the small aneurysm, the patient would like to keep the observation. They don't want to surgery or coiling or FD for very small one. They would like to observation. But for the ruptured very small one, if we perform the interventional treatment, I think that if we perform this kind of method of treatment with antiplatelet treatment with after deploying stent, I don't have the confidence of very successfully prevention of the rupture of the small ones. So in my department, for the very small aneurysm of paraclinoid aneurysm, even the aneurysm is covered the optic nerve, and a very small one near the very important anterior choroidal artery or PCOM. Our choice is clipping is first. Thank you.
Thank you very much.
Thank you, Professor. Yeah, thank you.
Thank you. We have Professor Vincent who has a question.
Vincent, please.
Thank you, Professor Yang. It is really important that we keep the various surgical techniques on top of the flow divert in this flow diverter eras. You definitely shared some parts of these terminal IC aneurysms that sometimes we really have no choice, but we have to do the trapping and the bypass. One common problem we have, even when we were going to do this trapping and bypass strategy, is when the aneurysm itself is actually part involving the fetal PCOM, and that you really still have to keep the patency of the anterior choroidal artery and the PCOM, and then that really limits where you're going to trap the distal part. You can trap proximally, but the difficulty is, while is this aneurysm that you cannot truly flow divert, you do the bypass to trap, but then the difficulty is where you're going to trap, especially with involvement and the PCOM aneurysm, the PCOM takeoff may actually at the body of the aneurysm rather than even at near the neck itself. So these are still some of these cases that is very challenging. And I'm just throwing the question on if there's any particular good solution, perhaps the suction decompression technique. But when I see this, I always have a headache. Thanks.
Thank you, Professor Huang. You gave me a very difficult question, and I understand the situation you're facing, and I'm prepared for that condition. But I have not seen that the aneurysm with the PCOM anterior choroidal artery rising from the body of the aneurysm. And even in this, from my second cases, before the surgery, we think that the aneurysm is so bubbling from the artery, and all the branches are rising from the arteries, from the aneurysms. But under the microscopy, we found that we have the method, we can remodeling it. We can remodeling it combined with the sonic technologies. I mean that after each clipper applied, we can test it, the perforator and those small arteries, if it's the patent and if their arteries running in the arteries. And this is the first I can do for myself. But to my acknowledgement that the paraclinoid aneurysms is rising, it should belong to some segment. And if the aneurysm is rising from the cavernous sinus, we can do it very safely with the FD or stent assist coiling. But if the aneurysm rising from the intracranial segment of the internal choroidal artery, to my experience, I never have seen aneurysm. So with so broad neck, the neck so broad, embarks the PCOM, MCA, ACA, is very rare. I don't have this experience. My suggestion that is that if next case I would encounter for in such a condition, I I would like to prefer a remodeling clipper with sonic checking technologies to make sure each perforator small artery is patent, and I will do my best to remodeling it to the best result. Thank you.
Thank you,
very
Professor.
much.
Thank you.
So thank you very much. We can take one last comment from Professor Hasigawa before we can move to Professor Otani for his concluding remarks. Professor Hasigawa.
Sure, thank you very much, and I would say congratulations on your great technique. So yeah, I agree. It's very nice to have very good surgical technique when you see aneurysm, even though you can do both endovascular surgery and also microscopic surgery. So you mainly do small craniotomy kind of keyhole surgery for small aneurysm, and you do bypass and some other advanced surgical techniques for complex aneurysm, right? So my little question is, would you what's the how to select the candidate for keyhole approach in terms of size or age or the shape or location of the aneurysm? What would you think about the approach selection?
Thank you very much, Professor Hirotaka. It's very nice to meet you on this conference. It's our first time. Thank you very much for your great question. And the keyhole approach I learned is the first time from Professor Badaski about 20 years before. And after that, I don't have the idea. I have the brief. I cannot perform it, and because I don't think it's suitable for me. But at that time, I'm too young. I'm not have the conditions, and but after about 10 years, I work with Professor Yoha with the same operation on the same table. I was his first assistant, and I see his technologies, the keyhole approach, and also with open incision on the forehead, like in this side. I think his method is similar with Professor Badaski. And with this approach, I think with the most of anterior circulation aneurysm, even for the post circulation, like the basilar artery tip of basilar artery aneurysm and the supracerebellum cerebellar artery aneurysm is okay. We can see the aneurysm and very clearly because they are unruptured. So I think with unruptured aneurysm, the size of maybe 10 milliliter or 15 milliliter size below, we can perform clipper successfully. But the very giant aneurysm, like the bigger than 25 milliliters on the textbook, which is belong to the giant ones, we perform this approach. We have some difficulties because we need dissecting the aneurysm from the neighbor brain and many important structures like nerves and the perforator arteries. So small one and middle size is okay because one or two clippers we can deal with it. But for the rupture ones, it's different because the rupture ones we are more difficult because the aneurysm ruptured and we may be re-ruptured during the procedure. we need to consider the proximal control first, and we need to consider that if we have the how many times we can adjust the clippers during the procedure. If we cannot perform the clipper once by one times, that's maybe a very disastrous situation. So my recommendation is that young neurosurgeons who perform keyhole approach, clipping for rupture aneurysm, would be better to perform more than 50 or 100 rupture aneurysm with triangle approach to see more clearly the situation and accumulate for their experiments. That's my ideas, dear
That is,
professor.
Okay, thank you very much. Thank you very much. Yeah, so normal side and exercise is normal. I mean, not large, then you do keyhole approach. But if it's rupture, you do standard triangular approach. Thank you very much.
Yeah.
I understand that.
Thank you very much. It was indeed a very wise comment and well taken. So thank you to both the speaker, Professor Shinyu Yang, and before we can close it with the final remarks from Professor Otani.
Yeah, thank you. I have so many questions about to perform the direct surgery for the paraclinoid aneurysm, Professor, but there's no time to discuss with you. So next time, I would like to discuss with you about these problems. So where discussion has performed, and I can learn so many knowledge and information through your presentation. Thank you so much, Professor Yang, Professor Yang. Thank you so much. Okay,
Thank you.
Raja, please.
Yes, thank you very much. So now we'll wind up this session, and on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers of today, Dr. Hirotaka Hasegawa, as well as Professor Shinyu Yang, as well as Jazz, Professor Vincent Eng, and Professor Naoki Otani for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 1,370 people who have joined us live from all over the world. A special thanks to my co-host Libun Singh for joining me today. So until we all meet online again tomorrow and next Saturday, it is bye-bye from all of us. Thank you very much for joining.